Just how you can hear me? All right, it's time to start. Before we start, we've got some people out with stomach something something or something else. So Friday is a natural science seminar. Aaron asked me to announce it. So here's his PowerPoint slide to announce it. We'll have a gentleman from the Toledo Zoo. We'll be talking about, I guess, bird and fish stuff from the looks of it, since he's in charge of the aquarium and he's an ornithologist. So that should be interesting. Who doesn't love the zoo? So that should be interesting. We'll have a sign up sheet in the back. Remember, you're required to come to 2 natural science seminars. You don't have to write anything if you come. If you don't come, then you will need to watch it when it is on the YouTube page. And yeah, I think I've said all I need to say about that. So Friday, please come. Also, I was looking at the syllabus. There's a major league goof in the syllabus. It says that there's a test on Sunday. I could give a test on Sunday. No one would come. So I don't see where the benefit would that be. The test will be a week from today. A week from today, the 25th. The material for that test ended when we finished talking about cholesterol handling and cholesterol, treating high cholesterol, and so on and so forth. That's all the material for that exam. So this stuff about angina, so on and so forth, that will not be on the upcoming exam. All right? All right, any questions about any or all of that? Yes, Lauren? Well, I'll probably write the test over the weekend, so I'll need them before the weekend. No, I will write the test over the weekend. That's the only time I have to write the test. So yeah, it'll be over the weekend. So I have to have them at least by Friday. Very good. Let's then go back to all right. There we go. All right. So we were talking about angina pectoris. Angina pectoris involves crushing pain in the chest, the symptoms of which listed on page 84. Substernal pain usually lasts less than 20 minutes. If it lasts more than 20 minutes, then it might not be angina pectoris. Tell me, can other things besides heart-related things cause chest pain? How about a zoster infection, varicella zoster infection of the mediastinal lymph nodes? Can that cause chest pain? Yeah, pretty severe chest pain. How about one of these long-standing upper respiratory viruses that can infect costal cartilage and cause inflammation of the costal cartilage. Can that cause chest pain? Okay, everybody go like this. Yeah, that can cause chest pain. How about severe gastric esophageal reflux disease? Can that cause something that looks like chest pain? Okay, everybody go like this. Yeah. So it was all chest pain cardiac? No, no. You have to establish that chest pain is cardiac first. You have to establish it's cardiac first. So some of the other signs indicate activation of the sympathetic nervous system. It's very often associated with heart-related chest pain, sweating, fatigue, nausea, epigastric pain, the Levine sign, so on and so forth. Those are all features of angina-type chest pain. The other feature are the EKG changes. EKG changes are very, very important. So there's a generalized term. It's called acute coronary syndrome. Acute coronary syndrome. Acute coronary syndrome does not include stable angina pectoris. It would include so it would include an ST elevation, myocardial infarction. It will also include a non-ST elevation, myocardial infarction. So remember, the ST elevation myocardial infarction involves a transmural death of the myocardium. The non-ST elevation involves damage that does not go all the way through the thickness of the myocardium, and then unstable angina. So virtually all cases of acute coronary syndrome involve rupture of an atherosclerotic plaque and partial to complete occlusion of a coronary vessel. Because classic angina does not involve rupture of an atherosclerotic plaque, it's not included in acute coronary syndrome, albeit sometimes the symptoms can look pretty similar to each other. So unstable angina is not predictable the way classical angina is. You typically get rupture of an atherosclerotic plaque. That plaque might be very small. The rupture may be partial. It may stabilize very quickly. You get some occlusion of the vessel. It's not complete. That blockage then gets cleared and the angina goes away, but it's unpredictable because if a plaque ruptures, it can rupture again. In fact, it usually will rupture again. Vasospastic angina involves spasm of the smooth muscle surrounding the coronary artery. That can cause symptoms that look a lot like angina pectoris. This runs in families typically. It can occur at rest, usually is not associated with any type of exertion. In fact, it can occur very commonly when you're in bed asleep. And myocardial infarction, of course, is that complete occlusion of a particular vessel. So my colleagues, sorry, I need to make sure that, okay, gotta stop that first. Come on, stop. You can stop, 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 stop. You're not stopping. There. Yes, fine. Thank you. Okay. Now, this is one thing I really hate about Zoom. You want to switch screens, it takes an act of Congress. So if we look at this particular ECG, this is from one of the people I'm friendly with on formerly Twitter, now X. This person's a cardiologist. So here's a 12 lead. So let's just go over this. So PQRST, PQRST, there's lead one. That look normal? Who thinks it's abnormal? Anybody? Who thinks it's normal? Raise your hand. Okay, we're pretty well agreed that looks normal. Here's two. PQRST. T looks a little high, doesn't it? Normally, T doesn't look quite that high. That might be in the normal range, but looks a little suspicious. So that one's kind of plus/minus. Can we agree 3 does not look normal? Is there anybody here who thinks 3 is normal? And if you think that's normal, I will ask you what you're on, because I want some of that too. Okay, no, that is not normal. What's abnormal about 3? Right, the TT wave is way too high. Way too high. PQRST. Okay, that looks like ST elevation. So it looks like you get ST elevation here and here. AVF, that's the one that goes towards the bottom. Get a little elevated, huh? Whoops. What's wrong there? Wrong way. ST is going the wrong way. If it's going the wrong way, that means what? Becca, what does that mean? Okay, I don't speak mumble. Speak up. It's not good. Ischemia. Ischemia. AVR. Wrong way. Ischemia. B1. Ischemia. B2. Look a bit normal. Oh, that doesn't look well, but that's not bad. That looks not great, but it doesn't look super abnormal.
So does an inverted T wave always mean ischemia?
When you have ST elevation, yeah. Yeah. Okay, 3 looks a little high there, but I'm not going to get too torn up about that. Okay, V4, V5, V6, these actually don't look quite so bad. So our issues are in 2, 3, AVF, inferior MI. And we've got ischemia here and here, here and here and here. Our problem's on the right side. So this is probably a right coronary artery occlusion, inferior MI. This is the sort of thing you're looking for. So this would be an example of a STEMI, because you have SC elevation, just like what you see on page 85. And occasionally when these people throw these things up from Twitter, X, sorry, I keep saying Twitter. Old habits die hard. Old dogs have trouble learning new tricks. I'll throw these up there and you can see essentially how to read these essentially and where the problem is, because the 12th lead gives you a nice 3D shot of the heart. So it tells you where the problem is. All right, let's go back to our slides. All right, so that's an example of myocardial infarction. Remember, there's two types: transmural, that'd be ST elevation, non-transmural, mainly endocardial, and some of the myocardium, that's N STEMI. So classical angina is precipitated by physical activity or stress. It's predictable. You have a mismatch between oxygen supply and myocardial oxygen demand. The pain starts gradually. It reaches a maximum intensity over minutes before dissipating, and it almost always results from cessation of the precipitating activity. The pain is heavy, crushing, squeezing, constrictive, usually located to the substernal area, may radiate to the neck. You must stop activity or decrease stress for the pain to stop. It's also stopped by nitroglycerin. This is different than non-classical angina, non-typical angina, unstable angina, which is not predictable and is not related to the event. So with unstable, today you can climb 5 flights of stairs. Tomorrow, you'll have pain at 3 flights of stairs. So typical angina, we already described. Atypical will have 2 of the above characteristics, and non-cardiac chest pain usually will only have 1 of those characteristics. There was a case once that a student working at the emergency room told me about once, where a lady came into the ED and she went to bed. She had chest pain. She had bad chest pain while she's lying in bed. It kept her up. She couldn't fall asleep. So she's not doing anything, but she still has terrible chest pain. That doesn't sound so much like cardiac chest pain, does it? She had an EKG just to be safe. EKG was normal. That really says it's probably not chest pain. Probably something else is going on that's causing her chest pain. Unstable angina may be similar, might be more intense, might not be. Usually persists for longer than 30 minutes, often not responsive to sublingual nitroglycerin, and it's usually the result of the rupture of an atherosclerotic plaque. Can be the result of vasospasm. That would be the so-called vasospastic or Prinz-Mental, or sometimes called variant angina. Spontaneous, occurs at rest, usually occurs cyclical, can occur at the same time each day sometime. Sometimes at midnight or in the early morning. Tends to respond spontaneously. Atherosclerosis may play a role in it, may not. Also may be associated with Raynaud syndrome. Raynaud syndrome. And again, there's usually a family history. So Raynaud syndrome, I think we talked about that before, but it's usually seen in the hands. You get usually a whitish to bluish color of the hands. There's like a line was drawn across the hand. It's most often precipitated by cold. You see this when you go out in the cold. You get redness going up here like this, and it turns blue. It's usually due to some sort of vasoconstriction, very often associated with some sort of autoimmune condition. Lupus, scleroderma, something like that. But it doesn't have to be, but it often is. All right, so we talked about myocardial infarction before, simply to say that you have a obstruction, you get myocardial ischemia and death. Over the first 24 hours, there's extensive necrosis of the area that was deprived of oxygen. You have hemorrhage usually in that area. On an echo, the fibers will look kind of wavy, usually. 1 to 3 days, you have extensive neutrophil infiltration. The neutrophils are trying to get rid of debris. 3 to 14 days, macrophages come in. You have granulation tissue at the margins. That's new blood vessels that are starting to be formed. Fibroblasts come in, they lay down collagen to make a scar. And then over the next 14 days, that scar will contract. Remember, scar tissue in the myocardium does not contract, and it doesn't conduct the signal to beat either. So the scar can potentially cause arrhythmias. Some of the most common, if you survive the heart attack, some of the most common causes of death are the arrhythmias that result from the beat, now trying to signal the beat, trying to get around that scar tissue. We went over these different classes before. Let's just go over them again. Class 1 does not occur with ordinary activity, such as walking, such as climbing stairs. Class 1 will only occur with strenuous, rapid, prolonged exertion at work or recreation, shoveling snow, running uphill, running upstairs, walking quickly uphill, something like that. Class 2 will occur with walking or climbing stairs rapidly, might occur after meals, or with cold or wind or severe emotional stress, or during the first few hours after awakening. Remember, cortisol production by the adrenal cortex occurs diurnally. The big peak occurs after you wake up. Most heart attacks occur early in the morning after you wake up because of that cortisol peak. Class 3, now you start having marked limitations with ordinary physical activity, walking 1 or 2 level blocks or climbing up 1 flight of stairs at a normal pace will cause class 3 type pain. Class 4 type pain then will occur with everyday normal activity and even at rest. This is a treatment algorithm for acute coronary syndrome. So if you have definite acute coronary syndrome, you'll treat with aspirin, with Plavix, otherwise known as clopidogrel, and beta blockers. If there's ST elevation, then you follow the STEMI protocol. If there's not, then you kind of just keep what you're doing. And if there is markers of damage to the heart, then you're meant to the hospital for further and more aggressive treatment. If not, you follow up studies and then you do a stress test. If everything's fine, then you send them home. If there's possible acute coronary syndrome, you give them aspirin. Follow up if everything seems fine, you send them home. And if it's not chest pain, then you figure out what kind of pain it is and treat appropriately. So it all turns around as to whether or not you have heart damage. Again, one of the ways you assess heart damage is with an echocardiogram and with blood work that looks for cardiac troponin. You're trying to prevent a heart attack and death, so you're going to look at lifestyle, diet modifications, beta blockers, lipid lowering agents, antiplatelets, nitrates. Nitrates are a biggie. Calcium channel blockers, if the patient cannot tolerate beta blockers, and then ACE inhibitors as well, will prove quite effective. Let's look at anti-anginal agents. These are things that can prevent heart attacks. So antiplatelet agents prevent platelets from sticking together. So should the plaque become unstable, these agents will prevent that ruptured plaque from occluding the vessel. So these agents will prevent a heart attack, they prevent a stroke, and they are also used after any sort of coronary artery bypass, graft surgery, or with hemodialysis. So the first of these is aspirin. Aspirin is taken prophylactically. You take usually a baby aspirin. That's 81 mg of aspirin per day. Kids' aspirin, of course, is flavored. You chew it. It gets absorbed very quickly. Because the activity of aspirin on platelets is irreversible, you prevent platelet activity, but you don't prevent any sort of activity in the endothelial cells, because the endothelial cells have a nucleus. They can remake their enzymes. So this is low dose, strictly antiplatelet. You can use an adult aspirin if more aspirin is called for, but you usually want to start at 81 mg. The big issue with aspirin, of course, is peptic ulcer disease. The other drug is clopidogrel. This prevents platelets from getting activated. One of the molecules made by platelets that activates them is ADP. There's an ADP receptor on the surfaces of platelets. It's the P2Y12 receptor, in case you're wondering. And clopidogrel and other drugs like it antagonize that receptor. Because they antagonize that receptor, they prevent platelets from being activated. Now, clopidogrel is a prodrug. Because it's a prodrug, it needs to be activated. And if you use other types of drugs that inhibit cytochrome P452C9, clopidogrel won't work. And one of the drugs that inhibits P452C9 are proton pump inhibitors. So clopidogrel cannot be taken with proton pump inhibitors. There are other platelet inhibitors you can give with proton pump inhibitors. Clopidogrel is not one of them. Sorry. 2C19, not 2C9, 2C19. Clopidogrel also is active at doses above 75. 75 is your low dose end. If you need to jack it up, you can jack it up further. Beta blockers. Beta blockers prevent angina attacks. They prevent angina attacks because they decrease the oxygen demand of the myocardium. So while beta blockers don't stop anginal attacks in their tracks, by taking them, you can prevent them. So these are prophylactic, much the way these drugs are prophylactic. So you're typically going to use your cardioselective beta blockers. So metoprolol is one of the big drugs that's used for angina. So is atenolol. Notice beta blockers, they end in LOL. OLOL. Your adverse effects will usually include bradycardia, fatigue, hypotension. If someone has congestive heart failure, beta blockers can, in some cases, make congestive heart failure worse. If someone has a heart block, beta blockers are contraindicated. They're also contraindicated if somebody already has really low heart rate. Nitrates will stop an angina attack in its tracks. So the organic nitrates work quickly. They get degraded to nitric oxide. Nitric oxide has the easiest chemical structure in the world to remember because it's just no. Nitric oxide activates guanylyl cyclase. Guanylyl cyclase causes a production of cyclic GMP. Cyclic GMP is kind of a universal smooth muscle relaxing intracellular signaler. Cyclic GMP levels go way up when you expose someone to nitric oxide. So all the organic nitrates degrade to nitric oxide. So they work quickly, they cause smooth muscle relaxation, they cause massive dilation of the coronary arteries, and they greatly increase oxygen delivery to the myocardium. Now they act systemically, so you're going to get vasodilation everywhere. That's one of the reasons for the side effects of these drugs. So they're used for all types of ischemic heart disease, not just angina. They can also be used prophylactically, as we'll see. There are versions of the organic nitrates that tend to release slowly. There are others that release quickly. And they're very useful for differentiating a heart attack from angina pectoris. They relieve the pain of angina pectoris, but they don't relieve the pain of a heart attack. So that's why they are in the algorithm for myocardial infarction. If you have chest pain, when you come to the ED, you get nitrates, an EKG, and then an acetaminophen to relieve the headache you get from the nitrates. So nitrates are going to reduce preload. Preload. So preload is the resistance against which the heart is pumping. The resistance against which the heart is pumping. If you take those vessels and you dilate the bejeebers out of them, how much resistance now is the heart pumping against? Very little. So they reduce preload. They will also tend to reduce afterload, the amount of blood left in the ventricles. So they reduce the workload of the heart. So you reduce the workload of the heart, that's going to reduce oxygen demand, and you increase oxygen delivery. You can see why these work so quickly and so effectively. So the two main products are nitroglycerin. So when you think of nitroglycerin, you probably think of dynamite. You probably think of kaboom. Yes, it's very effective for kaboom, but it's also very effective for treating angina pectoris. Isosorbide mononitrate tends to be a slower releasing molecule. So isosorbide mononitrate tends to be given prophylactically. That one will have a longer half-life. It'll take longer to start working as well. Nitroglycerin tends to work quickly, but there are versions of nitroglycerin that tend to be more for prophylaxis. Yeah, I had a table, I think, and I pulled it out. So page 90, there's a picture of the structure of the different organic nitrates. Nitroglycerin, you see, looks like glycerol, but the hydrogen of the alcohols has been substituted with nitro groups. This molecule, it turns out, is relatively easy to make. There's a little molecule I made when I was in high school called nitrotriiodide, where you substitute, you use an iodine solution, you get substitution of the nitro with iodine. And this stuff you can actually, it makes a crystal, and then the crystals you can put on the end of a meter stick. And if you whack the meter stick, it'll go pop, 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 pop. We used to play tricks on our band director. We'd put this stuff on his little podium. He'd get on it and it'd go pop, 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 pop. He's like, "Oh, what's wrong?" And of course, he'd whack his shoes and keep popping. And then he'd walk off the podium. His shoes are still popping. And it was a pretty fun trick we used to play on our band director. Um, yeah, don't try this at home. Isosorbides, as you see, are made using sorbitol. Sorbitol is used in various food products as an antifungal. And so the nitrates are made using the sorbitol as the starting material. So they're used for relief of cardiac pain. And then you have other versions of these that are used prophylactically. So nitroglycerin, for example, comes in a dermal patch. If you put the patch on, that's going to work prophylactically. It also comes as ointments that you can put on your skin. Those are used prophylactically. The most popular form of nitroglycerin is the sublingual form. Those come in small tablets. You pop them under your tongue. There's an oral form as well. It's not used that much anymore. Isosorbide mononitrate typically comes as a tablet, and that one has a longer half-life, and it's usually used prophylactically. The isosorbide dinitrate is usually used in combination with a drug called hydralazine. Hydralazine is a non-specific vasodilator. And the combination of the isosorbide dinitrate and hydralazine is a combination called Bidil. Bidil is used a good deal in heart failure. We'll talk about Bidil when we get to heart failure. Used a little bit for blood pressure, used more in heart failure. So again, these can be used prophylactically or as treatment. Side effects are number one, headaches. If you are prone to headaches, nitrates will make your headache a lot worse. That's one of the downsides of nitrates. Two, they can cause dizziness. That tends to be a first dose effect, and you tend to get over that. Three, hypotension. That's usually not something you get over. That tends to cause your blood pressure to bottom out to some extent. Now, tolerance. This is a specific type of tolerance. In order for nitrates to work, you have to have GTP. What happens if your GTP stores run out? The nitrates stop working. That is called tachyphylaxis. Tachyphylaxis. You develop tolerance to a medication because you exhaust a particular cofactor. And this is a type of tolerance that you see with nitrates. Phosphodiesterase inhibitors inhibit the enzyme that degrades cyclic GMP. So if you inhibit phosphodiesterases, now you're going to have very long-lived cyclic GMP. That's going to cause your blood pressure to really bottom out. In fact, it may cause your blood pressure to bottom out so low that you'll stroke out. So nitrates should never be used with phosphodiesterase inhibitors. There are some very popular phosphodiesterase inhibitors that are on the market. You might know them by trade names like Viagra or Levitra or Cialis or something like that. These drugs, of course, are used for erectile dysfunction, but they're also used for pulmonary hypertension. So these drugs cannot be used together. Nitrate tolerance, again, we talked about that. I'm just going to go on. So nitrates come in sublingual preparations. Those are the most popular. They come as a patch or a paste. The patch is preferred, but the patch is more expensive. Remember, when you put on a patch, you always date the patch and put the time on the patch. Secondly, the patch has to be applied to an area of the skin that is relatively hairless. Clean. 3, you always take off a patch, fold it in half, and flush it down the toilet. You never take a patch and put it in the trash can. Children like the feel of a patch, and they'll take the patch and they'll, what's that going to do to a kid? Oh, right? Kids have died because they've messed with patches that were thrown in the trash. You never throw a patch in the trash. Never, 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 never. And if you have a patient who has a patch on, make sure they understand that. 4, never get in an MRI machine with a patch on. There's a little bit of metal in the patch. It will mess with the MRI machine. So all patches have to be off before you climb into an MRI machine. You're going to put a patch on and it's a nitroglycerin patch, you should probably wear gloves. Same thing with the ointment. The ointment comes with an applicator. Only use the applicator. Don't use your hands. If you use your hands, wash them in cold water. Why cold water? Hot water opens your pores, causes the absorption of the material. Also, the vehicle in there is going to cause that stuff to flow into your hands. Your blood pressure is going to bottom out and you're going to faint. Use the applicator. If you get some on your hands, get it off your hands as fast as you possibly can. The paste also will tend to stain your clothes. Keep that in mind. And PO means per os. That means by mouth. Take those as directed. Remove the patch at night. You want to make sure that if you're using a patch, that you're going 12 to 14 hours on, 10 to 12 hours off. That's very important if you're using a patch. Otherwise, you'll develop tolerance to the medicine. So the tablets usually come in 5 milligram tablets. When you start out, you just use one. You can use more if you need to in order to get relief. You use it as directed. If you overuse it, you're going to get tolerance to it. Remember, the transdermal patches are used for prophylaxis. They're not used for acute attacks. You can use the transdermal patches with sublingual nitroglycerin, but be careful. But be careful. Ointments, again, use the applicator. Massage it into the area. Make sure the area is 4 to 5 inches square, no bigger. Nitroglycerin typically is stable at room temperature. If it gets warm, it's going to degrade. You don't need to keep it in the refrigerator or something like that. And after you are done with that area, make sure you clean it, clean the area before you apply it again. Sublingual nitroglycerin will come in a dark bottle that looks something like this. It's dark because sunlight can, or even room light sometimes, can cause it to break down. So it has a particular shelf life. Look at that shelf life, respect that shelf life, because that molecule has a finite shelf life. And if you use old nitroglycerin, it's not going to work. Also, you get people who put the nitroglycerin into their glove compartment on a hot summer day. What's going to happen to that nitroglycerin? Going to get hot and it's going to degrade. It's not going to work. Also, cellulose can react with nitroglycerin and degrade it. So never use cotton in a nitroglycerin bottle. Oh, I need to take it with me because I'm going on a hike. Oh, it clangs around in my purse, that or my backpack or whatever. That causes the pills to get blown to smithereens. I'll put some paper towel or cotton in there. Do you do that? Survey says no. Don't expose the nitroglycerin to cellulose. If you do, it'll degrade. Don't expose it to heat either. It'll degrade. Put it in the ice chest. Oh, that's weird, putting medicine in the ice chest. I don't care. Put it in the ice chest. That'll also keep it out of the light as well. Can you throw a couple in your pocket? Sure, sure. But you wrap them in a napkin? No. Wax paper. Use wax paper. So people will throw some in their pocket. That's fine. You can do that. But don't wrap them in a Kleenex. Kleenexes are made of cellulose. Use wax paper. In fact, sometimes the doctor's office will give you these little wax paper envelopes. They're not that big. And they look like a little, kind of cute little envelope. And they're literally for putting tablets in and putting them in your pocket. And when you guys start your own practices, you can actually get a box of those and have them. Oh, do you need some? Here's some. All right, so you'll notice that the isosorbide mononitrates, they have a later onset of action and have a longer duration of action. So the isosorbide dinitrate and mononitrates, they take longer to start working, but they will work for a longer period of time. The sublingual nitroglycerin, you can see, starts working right away, but it doesn't last for very long. The ointment lasts about 8 hours, takes about an hour to half an hour to start working. The patches, same thing, work up to 24 hours. Oral nitroglycerin is not used that much, and it Works usually about 2 to 3 hours. I went to a couple of pharmacists and said, how many oral nitroglycerin tablets have you distributed? One of them laughed at me and said, the last one I distributed was 3 years ago. Since then, I've not distributed one. So I checked with the manufacturer. They still manufacture it, but it's just not used that much. Nitrates and beta blockers can be used together. If someone cannot tolerate a beta blocker, you can give them a non-dihydropyridine calcium channel blocker. That would include diltiazem or verapamil. Remember, these drugs can't be used in people with sick sinus syndrome or who have a heart block. If someone has variant vasospastic transmental angina pectoris, the dihydropyridine calcium channel blockers work quite well. Nifedipine, amlodipine, those types of drugs. And so your calcium channel blocker is preferred for those who cannot tolerate beta blockers. And you can use them by themselves, in fact, in some people if the beta blocker is not warranted. Short-acting nifedipine is not recommended because of its tendency to cause reflex tachycardia. If you cause tachycardia, you increase the oxygen demand of the myocardium. You're going to increase angina pectoris attacks. So diltiazem and verapamil, or you can use the dihydropyridine versions that are available in the extended release forms that are long-acting. Those work too. These, remember, cause headache. So if you use them with nitrates, you can get an even bigger headache. Flushing, pedal edema, that means swelling of the ankles. And then constipation, that's usually with verapamil. Don't use them if you have an avioventricular block. And they're particularly good for vasospastic angina. Remember, these two drugs have drug-drug interactions because they inhibit cytochrome P450s. Be careful with those particular drugs. Verapamil inhibits cytochrome P450s 2D6 and 1A2. Yeah, 1A2. It's a moderate inhibitor of 3A4. And diltiazem is a 3A4 substrate and a moderate 3A4 inhibitor and a weak 2D6 inhibitor. ACE inhibitors, it turns out, decrease mortality and morbidity of people with coronary artery disease. So they are recommended, particularly in people with high blood pressure. If someone has coronary artery disease, you're usually going to start treating, even if their blood pressure is borderline. So the so-called HOPE study looked at ramipril, but it's clear that any of the ACE inhibitors could have been used in this study. They decreased morbidity and mortality. They don't really decrease symptoms, but they decrease long-term effects. Same can be said for statins. Several studies have shown that in people with coronary artery disease and with people who just had a heart attack, statin treatment, particularly intensive statin treatment, decreased morbidity and mortality. You want to make sure that the LDL goal is below 100 at the highest. Some doctors will even say, I would really like it to be below 70 in some cases. There are some newer agents that can relieve angina pectoris pain. So there is renozoline. This is a sodium channel inhibitor, but it's the late sodium channel current inhibitor. There is an extended release tablet. Therefore, this drug not only can relieve angina pectoris pain, it can also have some prophylactic work as well. So it tends to prevent calcium overload in people's heart cells who have angina pectoris. That decreases pain, it decreases diastolic tension, and the long-term effects of the drug are not terribly clear, but it is clear that it relieves pain associated with angina pectoris. Ivabradine is also a novel anti-anginal medication. It inhibits the so-called funny current that we see in pacemaker cells. By inhibiting the funny current, you essentially take that funny current and now you make it a lot less steep. That slows down the heart rate pretty substantially. It's distinct from what you see in beta blockers or calcium channel blockers as a mechanism. It's dosed twice daily, and it also can relieve the pain of angina pectoris. It can also slow the heart down and decrease oxygen demand of the myocardium. Renazoline seems to be pretty well tolerated. The sorts of things you saw in clinical trials were dizziness and headache, 5 to 10%. Constipation was seen in 1% of or less. Nausea was relatively common, but it goes away. Ivabradine is associated with bradycardia. You also get this so-called luminous phenomenon in your visual field. You tend to see a kind of halo around the things that you're seeing. These are mild and they're fully reversible, but they can sure freak patients out. So what does a prescriber do? You also recommend lifestyle modifications, increase exercise, a diet now that decreases consumption of red meat, increases consumption of vegetables and fruits. You want to make sure that their pain is relieved acutely and that chronically their long-term prognosis is better. And so you're looking at their H&P history and your protocol. So the arrows in your quiver essentially are lowering the blood pressure. That will make sure you decrease the myocardial demand. You want to give medications that are cardioprotective. If they've had a heart attack, you want to look at arrhythmias because arrhythmias are a problem after a heart attack. And then you also want to make sure that they have nitrates to make sure that they relieve pain of angina pectoris attacks and that they can have those attacks prevented by other types of medicines as well. On page 91, you have essentially your algorithm for treating different types of angina pectoris. This little algorithm here can show you as the angina pectoris levels get worse, you layer on medicines. So at stage 1 is going to be aspirin and nitrates. At stage 2, you will now add a beta blocker or a calcium channel blocker, and then you'll keep essentially layering on medications as the stages get worse. Any questions about treating angina pectoris, a consequence of coronary artery disease? Well, if not, then we will remember Wednesday, don't come to class. I won't be here. Just focus, enjoy focus, learn a lot, and I will see you guys on Friday. Okay, Josiah, get well, buddy.